Thank you very much, OncoDaily, for the invitation. Great to see you, Gemma. And to the audience afar, I hope you find this talk interesting. And it really is around patients and the expectations in some health systems that patients will travel for their care, where they'll choose their care, where they have the right to choose their care, and what they decide or what decisions they make is based on quality, reputation, is it technology. And this is looking particular focus at colorectal cancer surgery. But I also want to give an idea of the policy that informs this behind it. So the policy really is around choice and competition policy. Now, we always think of the US. I'm based in the UK. I'm an oncologist and also a health services researcher. But we always think of healthcare markets and competitions as being a US-based thing often. People can choose on the basis of price. People can choose on the basis of differences in quality for their care, not just for non-cancer treatments, but for also cancer treatments. The fundamental aim of it is to drive healthcare performance. I've got a picture of someone called Julian Legrand, who was very influential. He was at the London School of Economics, and he was a tutor of mine about 15 years ago. And one of the things that he was involved in the NHS was driving a change in the policy to improve standards or quality of care. And he said, look, health systems have targets. You need to do better. And if you don't do better, we'll tell you that you're not doing better. And you keep punching and punching and punching. But there's often very little improvement. The other option that they try is, well, the doctors think that they know best. Let the doctors decide how much money we need, and they will improve care. But actually, unfortunately, in most health systems, when that happens, there's a lot of wastage of money. It becomes inefficient, and there's lots of perverse incentives. So his idea was that actually, look, you have the National Health Service here in the UK. Care is free. It's reimbursed by the social health insurance or the NHS. However, if we allow someone to choose where they have their healthcare, and if they choose on the basis of outcome measures that this hospital is better than another, the idea is that the patient moves to that center, money follows the patient, and the other hospital loses income. If they lose income, they think, well, we're losing income because people think that other hospital's better. We need to get better. And the idea is meant to drive up the standards. So it's like a nudge, basically, or a market phenomenon where there's not price competition, it's a fixed price. But the movement of patients in these markets is meant to drive healthcare performance because of the threat of losing patients or money. Now, this happened and started in the NHS in the 2000s. And a piece of work, a 3-year project that I had, was to try and see, well, in the National Health Service in the UK, do people shop around for their cancer care? Are they prepared to travel for their treatment? When I was developing the project, most people said, well, no one travels, maybe 5% of people, everybody has their local care. But I sought to start to investigate that. And I think the first piece of work I did was actually based in prostate cancer. And one of the things that I asked, I had a data set for all patients treated with prostate cancer surgery over a 5-year period between 2000 and 2015. And the first question was, do patients travel to centers other than their nearest prostatectomy center for treatment? As I said, the hypothesis of others was very few, maybe 5%. I thought maybe a bit more. So this is the first map I'm going to show you. So here we have a map of England. You'll see the colored dots on the right-hand side. Those green dots tell you that those are patients who lived near the cancer center there, who had their treatment there. The orange dots are people who actually lived close to that center but went to another center. And the red dots are patients who lived closer to another center but traveled to the center of those green dots. What that basically tells us is that actually, as expected, most people are having local care. But I investigated other hospitals, and at the time, you'll see these crosses here. There were 65 hospitals providing prostate cancer surgery. You'll see a cross on the left-hand side in a sea of green. That's a hospital in a place called Bristol. And the green dots are all the patients who lived close to Bristol who had their treatment there. All the blue dots are patients who actually had another prostate cancer surgery center much closer to them, but they traveled to this center in Bristol for their care. No one had seen anything like this before. So we were finding within the NHS for prostate cancer surgery, where care is meant to be free at the point of access, people were choosing to go to this center. But it wasn't just this center, it was other centers as well. And we found that 1 in 3 men were shopping around for their prostate cancer care. They were younger, fitter, and more affluent. But the question is, why were they going to that center? If you take all of those 65 centers, there were some centers, as you can see on the left side, who gained more patients than they lost. And on the right-hand side, there were some patient centers that were losing lots of patients to these other centers. So there was a winners and losers phenomenon. But if you look at the centers gaining patients, these were all the early adopters of robotic surgery. These were all the centers, these 12 centers were all the early adopters, and they gained patients. So what happened to the other centers? Well, the centers losing patients were not doing a minimum volume of patients. They had to do 50 a year. So a lot of those centers closed. So you have patients moving for robotics, most likely. Other centers losing patients, not doing enough volume, and were closing down. So centers were actively closing. So what would you do if you were a center in the middle, neither gaining or losing, but you can see what's happening? You would naturally get a robot. So we saw this phenomenal diffusion of technology where only 15% of centers had robotic surgery. And by 2016, 85, 90%. Everyone has robotic surgery. And one of the biggest drivers was this competition. But the question that someone then has, well, if robotics was one of the major factors in driving this movement of patients, what has been the impact on outcomes? Well, we weren't collecting outcome measures at these hospitals, but we do now. And what this graphic basically shows you from the NHS, and there are now only 50 centers providing prostate cancer surgery. And this is a funnel plot, and the y-axis is basically rates of complications from prostate cancer surgery, severe incontinence, bleeding. And you can see, despite all of these centers having robotic surgery, there's still a huge variation in the quality of care in the National Health Service. So you have this situation where patients moved, centers lost patients, some closed, some got robots, but ultimately there's been no improvement in the quality of care. So that's the prostate cancer surgery story. But I was very interested to know, well, what's the story in other cancer types? And in the UK, we have 10 audits or registers of cancer, so bowel, breast, ovarian, lung, and we cover all patients treated within the National Health Service. We have a population of 55 million people, and we collect measures of quality at the individual centers, and those can be outcomes, so mortality, they can be toxicity after treatment, they can be complications after treatment, but they can also be, did this patient receive evidence-based care or not? And these outcomes are now being reported through the center, the National Cancer Audit Collaborating Center, and are available publicly. So we have a public system where a patient, public, clinician can go onto a website, click on the hospital, and they can compare themselves to every other hospital in the country for outcome measures. So which leads us on to colorectal cancer. And as many of us know, within colorectal cancer, despite some large randomized control trials being done, we know that there are increasingly surgeons who are using robotic surgery. But colorectal cancer was also interesting because it was one of the few cancers where outcome measures were also being published by the NHS. So we had things like 2-year mortality rates after bowel cancer surgery was one of the measures that we had. So the question was, in this particular study, which was published in the JAMA Surgery, was actually for all the patients receiving colon or rectal cancer surgery, so 44,000 in this period of time, so a large number of patients who had a choice of 163 hospitals offering this, was there any evidence that patients were shopping around or deciding to not go to their local center and going elsewhere? The factors that we were looking at to decide what could be the benefits of going to other hospitals. So we had 2-year colorectal cancer outcomes, so that was mortality. We designated whether the centers were a comprehensive cancer center, so 51 of those 163 were comprehensive cancer centers. There is an overall hospital rating that we have in our health service, good, bad, inadequate, and 12 were rated as inadequate. We also looked at the specialization of the unit. So only 31 of these 163 centers performed pelvic exenteration and would be a very highly specialized center. And although we weren't looking at people having this surgery, those centers that did provide it were seen as being of the highest level, potentially from a skill perspective. We had 22 robotic surgery centers, and we also looked at research activity. So I talked about prostate cancer, where 1 in 3 patients were moving. And we have here something very different, because in prostate cancer, there were only 65 units. There are 163 in the NHS. We found that 1 in 4 patients were bypassing their nearest center. So 25%, that was up to 30% for rectal cancer. And you can just see in the map those blue dots. So you'll see a little tinge of green, it's magnified. So we're looking at a center, my own center in London. And our hospital has lots of patients, these blue dots coming from all different parts of the south of England, despite those crosses, other bowel cancer surgery centers were there. And these patients were younger, more affluent patients. So the question that I wanted to ask was, well, what are the factors associated with that? And very clearly, we found that if you were a specialist colorectal cancer surgeon.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.